In this discussion, I'll be talking about dysphagia, and because there are many conditions to discuss, I'll do this in two parts. So, this is the first of the discussions. Look at this clinical presentation, something that we commonly see in our clinics. A middle-aged gent coming with dysphagia. Now, as we discussed earlier in our discussions, to make a diagnosis, we have to find what is the organ at fault and then what is the pathology. And here, finding the organ is easy because there's a inlet symptom as we discussed or a functional symptom. So we know that it's very likely to be a problem of the esophagus. Why I say very likely to be, you'll understand in a while. So, uh, but what is the differential diagnosis? So before you look at the next slide or the next part of the discussion, pause the video and write a differential diagnosis for this patient. Because the history we are going to take based on the differential diagnosis to find what is the possible pathology. So I'm sure you have listed all these. So these are some of the conditions which can give rise to dysphagia. So what is the history that you are going to take? So again, you can plan for yourself and then pause the video, plan for yourself, and then do a comparison. This of course fairly straightforward situation. So the age is important. Now here the person is 50 years. So out of the differential diagnosis that we have listed, one thing is of course malignancy is quite possible. Maybe of course age is no barrier, but generally after about 40-45 years, especially after 50, elderly people, it's likely to be a malignancy. If it's a more, so like starting from 30s, it could be a neuromuscular problem like achalasia. Then again, elderly people, CVA is possible. Some people can have dysphagia with this. So age will give you some guide, but it is not diagnostic. Duration, now here the duration is 3 months. So a malignant is a possible. And then even so getting a dysphagia after a stroke is possible. Now in things like benign conditions like achalasia, the duration is generally much more prolonged. And also the progression. In malignancies, you get a progressive jaundice. It gets worse and worse. And with a malignant condition, it initially starts for liquids. And then, sorry, it initially starts for solids and then also later they have dysphagia for liquids as well. So it's a progressive dysphagia starting for solids and then for liquids. Now think like achalasia. From beginning, they may have a dysphagia for both. And also some cases of achalasia, initial dysphagia is for liquids. And later it may include solids. And also where they feel the dysphagia. Now if they point to a very high point, and also if they say the initiation of the swallowing itself is very difficult, it may be a neuromuscular disorder like a CVA. But if the dysphagia they feel a lower part, then it's likely to be a mechanical cause, and also it could be something like achalasia. So these are so you can see many mechanical causes like esophagus, corrosive strictures, and all these strictures. So if it's lower, it is possible to be a mechanical or also something like achalasia, the functional situations, which is a motility disorder. So with these things, it is quite possible to have a one diagnosis or some form of a differential diagnosis. Now, if it's like a acid stricture or a corrosive stricture, of course, definitely they will have a history of corrosive ingestion. So it becomes very straightforward. So just to highlight some few things that we have anyway discussed already, because many students wanted me show slideshow, uh, so they can, it's easy to revise. So then I have from this one, I thought I include some slides which discuss opposite, which elaborates what I have already spoken. So as I discussed earlier, difficulty initially slow, neurological causes. So many neurological causes may be at fault. Now getting into the further inquiry into your the GI symptoms. Now in case there's melena, hematitis is not very common with CS vegas, but you can have melena. If that's there, you can be pretty sure that it's an ulcerative lesion, and also the appetite. Now, things like achalasia, they have a very good appetite. Even a acid stricture, they will have a very good appetite. Now, even in CA esophagus, initially the appetite is preserved. But if it's a gastroesophageal junctional tumor or a CA stomach extending into the esophagus, from beginning they have a loss of appetite. And all these dysphagias, if they can't take adequately, they will lose weight. And this is more predominant in the malignant causes. Things like achalasia, they can have a loss of weight, but it may be not marked as a CA. And then the systemic inquiry is very important. The respiratory inquiry is very important because they may have diseases unrelated to the disease. But because these people with dysphagia, they are very prone to get respiratory infections. One thing is due to aspiration. And also sometimes with malignancy, there may be fistulation in the bronchial tree where the respiratory symptoms will be very severe in that case. And especially these aspirations may happen in the night. So they will give a history of choking attacks in the night during sleep. And in malignancy, symptoms of local infiltration like severe interscapular pain, it's important to ask. And symptoms of secondary, especially the liver, a person may have right hypochondria discomfort. Then in the systemic inquiry, the neurological inquiry becomes very important, because in the neurological inquiry, you may find clues to one of the neurological conditions which is responsible for the dysphagia. And also in the medical history, they may be already diagnosed with one of the conditions. And then, so that's your systemic inquiry. And the past medical history, social history, everything is important because you're going to treat a person, and there may be clues like the cause for, or rather maybe some risk factors like alcohol or smoking, betel chewing, and also in the social history maybe that the person has consumed corrosives. And coming back a little bit to this the systemic inquiry in the GI system, I think the history of GORD also is important. A history of gastroesophageal reflux disease, because this may lead in two ways. One thing, they can have a peptic stricture, and also GORD is a risk factor for CA esophagus. Then at the end, by this stage, with a good history, it is possible to clinch the diagnosis. So this person we are presenting today, a middle age gentleman, 3 months dysphagia, it was progressive, and it was in the he was feeling in the lower part of the chest. Initially his appetite was preserved, but now he has some loss of appetite, and there loss of weight, and he didn't have any history of corrosive ingestion. So here we thought it's like to be a C. esophagus. So similarly, if you get another patient who has a long history and dysphagia uh, for both liquids and solids, and he recalls that initially it was for liquids, and loss of weight is not very significant, very good appetite over many years, achalasia is possible. So like that, you can come to a sensible diagnosis, and then you examine the patient with this your confirmed diagnosis by the history in your mind, because then you are going to look into physical science to confirm your diagnosis, or maybe to reject the other things which are in the definition. Like BMI is very important, because in whatever cause of dysphagia, the BMI may be low, but it will give you an indication how severe the problem is, and whether the person is pale, because they can have vitamin deficiencies, jaundice due to spread. Hydration is very important to check, and feel for the left supraclavian lymph node. In case it is palpable, it's very likely that it's a malignant cause, and also that it also has spread. Respiratory system important, because there may be evidence of respiratory tract infection. An abdominal examination, things like distension in advanced malignancy, there may be a ascites, or with the patient cachectic, it may be a scaphoid abdomen. And then look for uh, liver enlargement, suggest of secondaries and any epigastric masses, and look for free fluid. So the person we are discussing today had a low BMI, and there were no supraclavian lymph nodes, and the abdominal examination, uh, there was nothing positive. And what we have to remember is, now supposing you have a palpable supraclavian lymph node, or the person has a liver enlargement, suggestive of secondaries, or has ascites, then of course it means the disease is advanced. So with this in mind, so how are you going to investigate? So for this patient, now we thought it is a C. esophagus and had a lower BMI. Otherwise, the physical examination is normal. So what is the first investigation that you are going to do to confirm the diagnosis? I'm sure you know what it is. Now, if it is another pathology you are thinking, say like achalasia, or you are thinking it's a peptic stricture, or the person has taken corrosives. So then what is the initial investigation? So in all cases of dysphagia, your initial investigations has to be a upper GI endoscopy. Now, if it's a definite stroke in the acute presentation, you may not rush to do upper GI endoscopy. But in other cases, with this malignant, or you think is a benign, like achalasia, or a peptic stricture, or even like something like a pharyngeal pouch, your initial investigations do a upper GI endoscopy and exclude a mucosal lesion. And in this patient, this is what we saw. The person has a CA esophagus, and then biopsies were obtained, and it came as a squamous cell carcinoma. Now there are instances where we see a lesion, a malignancy, we take biopsies, and the pathologists report that there is no malignancy identified in the specimen. In that case, what are you going to do? It's a very famous question that is often asked. So are you going to say, okay, it's negative, reassure, send home and review? No, you can't do that. Why? Because these biopsies are sample biopsies. You take the endoscopic biopsies and also very small pieces. Unless you have taken your biopsies in the proper malignant areas, or you have taken some necrotic tissue or not at the proper site, there may be no malignancy identified. So if you get a positive report, like in this patient we get squamous cell carcinoma, there's no problem. I mean, it's confirmed. But if the pathologists say no malignancy identified in the given specimen that we have sent. It's very important to discuss with the person who performed the endoscopy, and or maybe he has already provided the notes, maybe photographs. So if it's definite malignancy, there's no question that you have to repeat the biopsy again. But in a very sort of thing where there's sort of minimal suspicion and there's nothing, and the endoscopist says, okay, no problem, we can watch, then it's a different issue. So you have to be very careful. If there's a lesion, it comes negative. So it has to be repeated. So in this person, it was a squamous cell carcinoma. Then, like in any malignancy, then you have to stage. So the standard is to do a CT chest and abdomen. The CT chest, you see whatever features of local infiltration and any lymphadenopathy in the thoracic cavity, and the abdomen, especially to look for liver mets and the celiac axis lymph node enlargement. And so our patient, the CT chest and abdomen, showed a T2 lesion, and there were no metastatic spread. What are the other investigations in a C. esophagus which are useful? Endoscopic ultrasound. Now, endoscopic ultrasound, one thing, is not freely available. Now, and in all cases, it may be not necessary. The CT chest and abdomen will give adequate information. But especially in very early malignancies, where in some countries they do mucosal resections in the T1 lesions to look at the lateral spread, the endoscopic ultrasound will be helpful. And it is done with a special endoscope, where at the tip of the endoscope there is a ultrasound device, and when you place the endoscope at the area of the malignancy and you activate the endoscope, you can look at the lateral spread. And also it's important to understand that if there is a total occlusion and you can't pass the endoscope across, you can't do endoscopic ultrasound, and in this type of situation there won't be any much of a use also. And MRI also you can be used to assess the malignancy, but in current practice it's not routinely done. So in current practice, what all is necessary is upper G endoscopy, look at the biopsy, and then do a CT chest and abdomen. So our patient now is a diagnosed squamous cell carcinoma in the mid-esophagus, and the CT chest reveals a T2 lesion, and there are no metastatic spread. So as in any other malignancy, next is to assess the fitness of the patient, because the treatments has a significant morbidity, so it's very important to assess the fitness. So from your patients that you see in the wards, find out how this is assessed, and it's a very common thing, and I don't think I will discuss on that matter, but it's very important to review the history and then whatever investigations. But one thing I'll mention here is that doing the respiratory function tests are important if you're planning to embark on surgery. So now we have a diagnosed patient of C. esophagus, and his assessment was good. He had a fairly good fitness for any form of major therapy. So then we decided that we do a esophagectomy. So because it is resectable and there were no mets. Well, of course, you can discuss with your oncologist, even if you plan esophagectomy, whether you are going to offer neoadjuvant therapy for the patient, so that you can discuss with the oncologist. Now, because it's a squamous cell carcinoma, the other form for curative treatment is to give radical radiotherapy. That is also possible. But generally surgery is considered to be better, but you can always discuss. If the patient is an educated patient, you can discuss. So the balance of the discussion about esophagectomy and then the other conditions that were listed in the differential diagnosis, I'll do in the second part of this discussion. So it's better that you rehearse what we discussed for the history, examination and investigations before you look at the second part of this discussion.